David Davis.
Thank you, Mr. Deputy Speaker. I congratulate the Minister on a comprehensive report. She's clearly done a great job of identifying the numerous factors that exacerbate this problem and acting rapidly on them. However, of the first 26 doctors to die from COVID-19 in the National Health Service, 25 of them were from minority ethnic backgrounds. These doctors will have been comparatively well paid, so poverty cannot be the full explanation there. Vitamin D deficiency is prevalent across virtually all the groups that suffer disproportionately from COVID-19, from the elderly to the obese to diabetics, and including ethnic minority communities. Today's review only considers 2 studies on this and doesn't consider the huge range of new evidence that's come out in the last month or 2, showing powerful links in this area. Will she now do what her colleagues at the Department for Health are committed to do and look again at the latest evidence on this matter?
I thank the Honourable Gentleman for his question. We did look across a range of issues as to why that might have been the case. It was the number of ethnic minority doctors who had died right at the beginning of the pandemic that alerted us to this issue. So I would remind him about the point about occupational exposure. Occupational exposure, we believe, is the biggest cause, and they were the most exposed, probably doing the shifts right before we knew what was going on, catching the virus much earlier. We also looked at things like vitamin D, for example. SAGE, the 23rd of September report, they looked at studies on vitamin D to see if that had had an effect. They didn't find any relationship. So we have found that there is a small residual risk. And I'm looking at the interaction between comorbidities and occupational exposure, we think would explain this. We had a second literature review and stakeholder engagement report where many people talked about their experiences of systemic racism, and this was something specifically I asked RDU to look at. But the findings we've come out with do not support that. So, for example, when we take into account comorbidities, Bangladeshi women and white women have exactly the same rate of infection and death. That's what our findings had. Mortality rates, not infection rates. So systemic racism doesn't explain that. It also doesn't explain the differences between various groups like Black Africans and Black Caribbeans. If it was systemic racism, that's what we would expect. We would expect those things to match, and they don't. So there's still quite a lot going on, and that's why we're looking at those things, the socioeconomic, geographical factors, occupational exposure, population density, household composition, pre-existing health conditions. And we will continue to do this work. Remember, this is the first report, not the last one, and this review will be ongoing. Thank you.